So we've got a few more assessments that we'll talk about in practice in the next lab. So we'll be looking at the use of a dynamometer and assessing and documenting grip strength. So you will learn how to correctly use a dynamometer and how to document the results of grip strength testing. You also want to consider what some functional assessments are. So thinking about top down versus bottom up. Top down, using occupation to assess grip. Bottom up, using the actual dynamometer as the component to testing grip strength. And as you do your documentation, you want to clearly document this, what the dynamometer says, and if it is or out of range. But you also want to pair that with function. So why does it matter that you're doing the dynamometer testing? What does that functional component of grip strength look like to justify why you're seeing your client? Similar to pinch strength, using the pinch gauge, learning how to use it and then documenting the numbers, but more importantly, why do the numbers matter? So again, what functional assessment are you pairing with the pinch gauge to identify what the barriers are for your client and why they need your unique services, and making sure you document the why. So the numbers are critical so that you can document progress over time, and also what are the functional limitations and why they need your unique services. Also, you're going to evaluate and document sleep. Sleep is very critical. It is an occupation that is in your OTPF. So you want to consider how sleep dysfunction could impact overall occupational performance. So you want to think about and ask questions related to sleep preparation and how that impacts sleep participation. So if your client has pain, let's say, and that preparatory aspect of sleep, so settling in, are they uncomfortable and then not really able to prepare for sleep because they've got pain, and then that interrupts their participation in sleep. So how do you ask those questions to get the answers to then provide interventions? Or how do you evaluate how they're able to participate in sleep? And then documenting that. Asking questions about how long it takes them to fall asleep. Asking how long they're able to maintain sleep. Asking them how they're able to stay sleeping, or do they have daytime sleepiness? The impact on all of this with occupation. There is always going to be an influence of pain and fatigue on sleep. You might see disturbances in balance, vision, strength, all of the sensory systems related to poor sleep hygiene. And we have skin integrity there. So if you think about somebody who has thinner skin, or maybe sensory impairments, and they are either not able to roll during sleep, or if maybe they're doing a lot of tossing and turning, how skin integrity could be impacted. Think about the psycho-emotional status, their psycho-emotional status, and how that impacts sleep, either oversleep or undersleep. The impact of life on sleep, and nicotine, caffeine, alcohol use, etc. And the impact of their environment. So if the client is at home, is there environmental influences that are impacting sleep? If they are in a change of location, in a hospital, for example, in a nursing home, how is that influencing sleep, and how that potentially is changing and disturbing sleep? And for the case studies that you all are working on this week, it is they are hand related. So really thinking about how pain and positioning can disturb sleep. So making sure you're asking all of those like occupational profile questions related to sleep. You will be evaluating and documenting balance. This should be pretty familiar. You've done the tug, you've done the 30-second sit stand. The Berg balance is also an interdisciplinary assessment that you might see, or you might see the results in your, for a physical therapist is performing that. Always, what is your functional assessment? So you have the numbers of the tug. Now you can use those numbers to identify if the client is at a fall risk, if there's an impairment in balance. But why do those, and you can use those numbers to track change and improvements, but also functionally, why do those numbers matter? And as you're documenting, you want to think about documenting, do they have good balance, fair balance, or poor balance? And balance is not just standing, it is also sitting. So when we talk about trunk control in just a minute, you also will be using, good plus minus, fair plus minus, poor plus minus to document both standing balance and sitting balance. And standing balance and sitting balance are not always just static, they are also dynamic. So you want to think about, is their balance static sitting balance good, but their dynamic sitting balance is fair? And how far out of their base of support, think OTM 525 when we talked about center of gravity and base of support, how far out of their base of support? So they might, with a minimal excursion out of their base of support in sitting, have good sitting balance, but with a more moderate excursion out of their base of support, now it becomes fair. So, and the environmental factors, are their feet on the floor? Are they holding on to something, a walker or a table or you? So those are all components that also will impact balance and your documentation of balance. And we are always assessing our clients. If you're seeing them in the home, in outpatient, in the hospital, both acute hospitalization and rehab, are they a fall risk? So we're assessing that as well. So this should also be pretty familiar. So when you're assessing posture and trunk control, are your client's feet on the floor? And this is not just in sitting, this could also be in standing, because if you're working with somebody who has an amputee, their trunk control and balance and posture is going to look different because they might not have 2 feet on the floor. So these are all things to consider. Are their feet on the floor both in sitting and in standing, and how does that influence trunk control and posture? Have you set the environment up for success? There's so many environmental factors that can impact and influence posture, trunk control, and balance. So it's always something that you need to be thinking about. Have you set the environment up for success? As you're assessing posture and trunk control, you are looking at righting reactions, equilibrium reactions, protective reactions, postural stability and balance. So are they able to direct their head to an upright posture? Are they able to sustain and maintain a posture? Are they able to extend their arms and hands for a protective response? So these are all aspects of documenting posture and trunk control and assessing posture and trunk control. Does the client have the ability to maintain a neutral trunk and neutral pelvis? Or do they sit in an posterior pelvic tilt or an anterior pelvic tilt? Are they stabilizing outside of their core muscles? So are they stabilizing on their pelvis? Are they stabilizing on their low back? Are they stabilizing using their arms and their hands? These are all part of your evaluation. Are there any asymmetries in the pelvis, anterior, posterior, lateral shifts, etc.? Are they able to maintain midline? And this is in the bed, in seated, in standing. And then thinking about how other systems play into posture. So vision, do they have their glasses? Does that impact their ability to maintain their posture? Their cognition, their overall endurance, their overall strength. These are all key components that play into what you're evaluating, how you're evaluating, and then how you're documenting it. And all of your documentation always goes back to, this is what I see, this is how it impacts their function. This is how it impacts their ability to engage in occupation. So we talked about good, fair posture, good, fair, poor. So when you're looking at balance and trunk control, you're also using good, fair, poor. You will never, ever, 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 in seated and in standing, the first time you are working with a client and until you've assessed adequate trunk control, you will never, ever, ever leave your client seated, standing, unsupported, unattended. Ever. Because if you have not carefully evaluated adequate trunk control in seated and standing, and you walk away from your client, they are at risk for falls. All right, so we're going to dive into now the upper extremity. So we talked about grip strength, pinch strength, we talked about sleep, we talked about trunk control and balance. Now we're going to talk about peripheral nerve injury and peripheral nerve testing. And these are must-knows for your exam, for your NBCOT exam. So you need to know by the book the evaluation and intervention protocols for hand and upper extremity disorders and deformities caused by peripheral nerve injuries. So some injuries and deformities that you might see, and these are must-knows, median nerve injury, you might see an ape hand or hand of benediction, and the deformity is the inability to oppose or flex the thumb, which creates a flat palm. So when they're trying to make a fist, the first three fingers remain extended, which gives it that appearance of the hand of benediction, and that flat palm creates a quote-unquote ape hand. And the causes of this could be an injury at the wrist or elbow for a host of different reasons. An ulnar nerve injury, you might see a claw hand, and this is a deformity at the fourth and fifth fingers, show hyperextension at the MCP joints and flexion at the IP. There's wasting at the hypothenar eminence, and this could be any sort of ulnar nerve injury could be the cause. And wrist drop, related to radial nerve injury, where the hand hangs limp at the side due to paralysis of the extensor muscles. And this is often some sort of fracture or a compression, prolonged compression. And then for all of these, median, ulnar, radial, prolonged compression can be definitely a cause for all of them. So some peripheral nerve testings that are must know. So Finkelstein test, testing for de Quervain's tenosynovitis. This is a painful condition with the tendons of the thumb side of the wrist caused by inflammation. Placing the thumb inside the fingers, making a fist, and deviating the wrist towards the pinky side. And pain is a positive sign. Phelan's test, this is for carpal tunnel. Most of us are probably most familiar with carpal tunnel, a painful hand condition caused by compression of the median nerve. So you're holding the dorsal sides of the hands together with the wrist fully flexed for 60 seconds, and any sort of pain, numbness, tingling is a positive result. And Tunnell sign for cubital tunnel. And again, this is compression, ulnar nerve. So you're going to use your reflex hammer and do light tapping over the nerve to see if it causes any pain or pins and needles. Must know information. Oops, sorry. So this is examples of what the ape hand or hand of benediction, wrist drop, claw hand might look like. And then brachial plexus injuries. These are damage to the network supplying the entire arm. So you might have an Erb's palsy, most familiar with for children, caused by traction during birth or trauma, or Klumpke's palsy. So the Erb's palsy is the upper plexus, and Klumpke's palsy is the lower plexus. So the Erb's palsy, waiter's tip position, Klumpke's a claw hand position. So these are all must-know informations. We are going to do a refresher on range of motion. So just refresh for you, all positioning of the client is critical, positioning of the goni, how to read the degrees, and then thinking about your functional assessment as always. And you all will be designing your own 60-second functional or quick and dirty range of motion manual muscle testing assessment, and thinking about sort of a gross estimation of how somebody is performing. So grossly they're within normal limits, grossly they're within functional limits. And then if you are identifying that there is an impairment in range of motion in a particular upper extremity, you need to identify how it is impaired. Just saying impaired is not enough. So it's specifically which joint, what that impairment looks like. Did you need to pull out your goniometer? Was it identified during an ADL? And also, is this baseline or is this new? And manual muscle testing, all of this should also be familiar. Positioning of the client is important, at where you provide stabilization and resistance, and then what is the grading of the strength, and going back to your functional assessment, within functional limits, within normal limits, is it impaired, and how much and why. And when it comes to manual muscle testing, knowing which diagnoses it's contraindicated for manual muscle testing. So your clients with cardiac or sternal percussions, your clients with cervical spine percussions, contraindications. There are other diagnoses that you might find that there are contraindications for, that you would not do formal manual muscle testing, but you can still do a gross estimation of their strength. So are they able to raise both of their arms above their head or one arm above their head? Grossly 3 out of 5. Are they only able to go to shoulder height? Did you need to put them in gravity eliminated? Grossly this amount of strength in this joint. So you all will have the opportunity to practice all of this, and I will see you soon.